everybody, welcome to the New Zealand Shoulder Elbow Therapist Conference here in Aotearoa. I'm Margie Old, and everybody's going to introduce themselves and then enjoy our podcast.
Hi, I'm Pratnya. I'm a physiotherapist from Auckland.
Hi, I'm Lisa Hanson. I'm a physio and hand therapist from the Waikato, and I'm the matriarch. I'm the oldest.
Hi, Angela Cadogan, specialist physiotherapist from Christchurch.
Hi, I'm Sarah Betteridge, physiotherapy specialist in shoulders in Christchurch.
Hi, I'm Paul Timothy. I'm a physiotherapist in Christchurch.
And I'm Jane Dickerson. I'm a physiotherapist in Dunedin.
So welcome to our chats. I hope you enjoy the podcast. Hey, so welcome back to Glenohumeral Gurus. Behnam Liaghat, it's so nice to have you back. And for this series, we termed this the New Zealand Shoulder Elbow Therapist Fireside Chat. So the plan for this series then is 30 minutes, rapid fire. Any questions we want to ask you, you're the guy in the hot seat. So welcome. It's so nice to have you back and great for making yourself available.
Lovely, Margie. Thank you so much for having me again. I really enjoyed our last conversation, and I've received tons of great feedback and questions from clinicians out there. I'm so happy to be here again.
Yeah, wonderful, wonderful. So our first question is from Ange Cadogan, who's a very experienced therapist here in New Zealand and would love to join us, but is currently away on holiday. Her question is around rehabilitation and strengthening. She says, what are the differences, if any, in strength training or adaptations in the hypermobile versus non-hypermobile population? The clinical applications for dosage, intensity, frequency, rest intervals, etc. for a hypermobile patient. Her observation is that people with hypermobility fatigue more rapidly, adapt more slowly, and need more recovery time. She wondered about any physiological or other basis for this and how she could periodize or plan her programs better. Do you have any thoughts or answers for her?
Well, I think it's a valid and very, very, very great and reflective question. First of all, I would say that we can use high load strength training or progressive strength training as part of the rehab program, but a rehab program doesn't always include high load strength training. So we need to somehow be clear about that when we design a rehab program for the client. And what is important in this population is that it's not always realistic to introduce high-low strength training, at least not in the beginning of a rehab program. And sometimes what we consider to be high-load strength training isn't necessarily high-load strength training for that patient, or it's not considered high-load strength training because it's not using high loads. Because, as you mentioned in the question, that the patient can get fatigued, and sometimes many patients experience lots of pain when doing these exercises. And that means that you don't necessarily, although you have the aim of providing high-load strength training or progressive strength training, you don't necessarily achieve that in the exercise program. You introduce exercises that could be used in a high-load strength training program, but the load isn't sufficient, you could say. And most of the studies looking at high-load strength training, and most of the recommendations, international recommendations that we use, they are commonly based on data on healthy, young populations without pain, without mechanical symptoms. So what we need to consider when we provide high-load strength training to patient groups is that we really need to adjust some of the theories and some of the exercises and dosages to that patient. And a good way to somehow design a training program for hypermobile individuals, especially talking about the hypermobile shoulder, is to design it in a way that you respect pain, but not only respect pain in the current situation, but also pain development during the training program. So that could be in-session pain development. So you look at what we call pain flares or exercise-induced pain, where you somehow control it and also limit it from getting worse. An example could be that if you start with a pain on the NRS, numeric pain scale, if you start with a pain around 4 out of 10 NRS, you would start maybe with the first set and then ask the patient, how is your pain now? If the pain is still on a 4 or maybe 5, you could do the second set. But if the pain now is on 7, you can't continue with the third or the fourth set as would be recommended in a normal guideline. You should probably stop or give them a break. If they are fatigued, give them a break, maybe do something more not related to the shoulder, but some exercises like biking or something related to the cardiac system, and then return if the pain is calmed down. You can return to doing the third and fourth set again. So there are many considerations about how to apply progressive high-low strength training in hypermobile shoulders, and it really depends on the symptom development.
And so that people should monitor those symptoms based on, and how that would flare over the course of that exercise. I like your idea of starting, because the exercise can stay the same, can't it? But then you could start with a much lower weight than what would be considered high load, but maybe eventually, eventually it would become high load if you could persevere through. Is that the message?
Yeah, and sometimes, I mean, we are running a case study on a hypermobile EDS patient. And what we can see is that you don't necessarily, when you do high-low strength training, you don't necessarily increase, but you can maintain the same load, but do more repetitions. You can do more sets, or you can do the same amount of dosage or dose without having more pain. And that is somehow also progressive.
Yes.
Maybe not in terms of like basic physiological progression, but in terms of addressing this client's symptoms, it is progressive because you can do the same load but with less pain.
Yeah.
And that is also more quality in the exercise program.
Yeah.
And what we find in this case, what is very interesting is that the patient says, okay, when I've done strength training before on my own, I have success maybe for 3 weeks, 4 weeks, and then I have much more pain. And then I stop doing the exercises. But by introducing supervision by a physio or a skilled personal trainer or so, you have something to go back to. You have someone who is guiding you and making you return once you're ready, making you return to that exercise program again.
Yes.
And that gives you the continuous exercise, which is also a way of looking at progressive strengthening.
Yes.
Is by continuing it for longer durations and not stopping after 3 or 4 weeks, because then the physiological adaptations are not there. They're not present.
It's difficult, isn't it? Like you say, because you often then would start and then it would be painful, so then you stop. So then you get that sort of boom bust approach to it. And so then there is no physiological change, isn't it? I typically start thinking about, building some endurance and endurance capacity before you move through that, I guess. And that's what you're saying, but even saying keeping the same load, but more repetitions or holding for longer or whatever that might be. Yeah.
Yeah. And what is very important is the quality of movement in this population. I mean, the quality of movement is really key.
Yeah.
I have many patients where I give my second opinion. And a recent hypermobile shoulder patient I had, a patient with hypermobility in the shoulder, had tried progressive exercises for a couple of months, and the pain had increased. And so her physio asked me to have a look and give my opinion about it. And what I found was that all the exercises were relevant. All the exercises were some of the ones I would recommend,
Yes.
but the quality in the
Okay.
scapular movement and the coordination between humerus and the scapula was, to say it honestly, awful.
Mm.
And that means that by simply adjusting range of motion, limiting range of motion to where the quality of movement was present, and limiting the range of motion where the scapula was stable instead of
Yes.
like downward rotating too early or going into a protracted position too early and giving mechanical symptoms in the
Yes.
glenohumeral
Okay.
joint.
Yeah.
By addressing those small things, I mean, by one session, the patient
Then
was
you can
much better,
layer.
you know,
Yeah,
then you
isn't that
can,
amazing? Isn't it? And so I guess the your feedback for clinicians then looking at this program and this work you've done is to really focus on the quality of the movement. And am I correct in saying making sure there's a stable scapula before you then get, yeah, so then you get enough movement. It's so nice to dig into the detail with you about these things because it's just finding out. Like you'd be like, ah, I tried that with my patient and it didn't work. But because we don't understand the detail. I know
then,
Pradnya
yeah.
had some questions as well. She was very interested in our podcast. Pradnya, what's your question?
So I think that's a nice start from what you've said, like in with the progression, like heavy resistance, but it starts with the quality of movement, and there's a sort of a progression to it. So I guess my question probably maybe, I mean, what your thoughts are, and like what I say is sometimes you can like start with an isometric, and then once they have like they can be loaded heavy in isometric, and then through range kind of progression that would be appropriate, I suppose.
Yeah, I mean, there are different ways of putting a program together. I prefer
Yeah,
using some of the exercises or movements that you are going to introduce as a progressive high-load strength training exercise, using them as a coordination or muscle activation exercise in the beginning.
control.
So
Yeah,
let's say we're going to have a prone lift of the arm or prone external rotation of the shoulder in 90 degrees of abduction. I would introduce that without load and try to make that movement work before introducing it with load. So that is the way I normally use the exercises. But if you have lots of pain, we know from my research project, the randomized trial, that many patients benefit from isometric exercises as well. And
so you did try sort of isometric initially in some of those symptomatic patients before.
yeah, we didn't like progress from isometrics to high-low strength training, but we did the comparator group in the randomized trial. They did isometrics in the beginning and posture correction in the beginning, and then moved on to TheraBand exercises with light resistance.
Yeah,
But that was again from in neutral to mid-range position and not to the outer range. So,
okay,
so it was a way of building up capacity in the inner range before moving on. But we didn't do that in the trial. We didn't move on or progress to high-low strength training afterwards, which is what I would do in the clinic.
right,
Yeah, because I
okay,
think that's been our approach, hasn't it, Pranya? To start isometric, build
yeah,
capacity, build them below
build it,
shoulder height, build them above, and then layer them up so that they can hang on their pole dances or they can take contact. Like I think we have quite a lot of hypermobile patients who have quite high load demands. So, but that's
yeah,
typically how we've done it, but we can try a different way and see.
Yeah, with my background in sports physiotherapy, I mean, I think lots of functionality in the exercises. So if you have an overhead athlete who's going to throw,
Mm.
then it's important for me to introduce that motion or that movement very early on in the
Mm.
rehab.
Mm.
So that's why I would prefer to introduce lighter exercises, but still use the range of motion they are going
range.
back to. And so that is my sports approach, I would say.
Yeah.
But it's absolutely fine
Yeah,
to use isometrics to activate the muscles, but also get to learn the small muscles around the shoulder.
Yeah. And so maybe the take home for us, because you get lots more buy-in from athletes when you can show them that you're
Mm.
replicating that same position, don't you? And so maybe that's a good thing for us to try and incorporate in a way that's pain-free, depending on their position. Was there
Yeah.
anything else, Pranya, you had? You had some other.
Question. I think then probably my thoughts were more related to like even in hypermobile symptomatic patients, because they can have a different direction of instability. Like my approach has been depending on the direction of instability and the weakness in those, I guess, direction specific muscle groups. The exercises vary, but I see that in your study you had a set of exercises. Mainly they seemed like more sort of posterior cuff with scapula. Is that what you always go towards, or because we sometimes start with like, subscapularis, where in outer range, if it is weak, we focus more on that. If they have the direction of instability is more anterior. So do you change those exercises, or how do you approach depending on the direction of instability?
Well, what we found out in the randomized trial, where we had these 100 patients included, was that they had a range of different instabilities or hypermobility directions. And what we tried to investigate in a study was, does it matter what kind of instability or what kind of laxity or hypermobility you have, and in which direction? Does that somehow relate to the symptoms and the self-reported function? And we found out that it really doesn't. So
Oh,
my
interesting.
message regarding that has been that it's still useful to do the clinical tests, although they are very different in these patients, and they're very unique. And it doesn't really matter regarding pain and function if you have 1 out of 10 tests positive, or you have all the 10 tests positive for shoulder instability and shoulder laxity and so on. So my message has been that the reason why we still do these clinical tests is to understand how to design the exercises. So I totally agree with you that if you have instability in one direction, you should design the exercises in a way where you respect that instability. So you try to avoid mechanical symptoms due to that instability or laxity, and you design it and load it with respect to what happens in that area during the progression of exercise. And then you have, obviously, you have different directions you could load the muscles. And again, it depends on where the weaknesses are. We know from research, I know from my own practice, that it's often on the posterior side of the shoulder that weaknesses are severe. But of course, if you have overhead athlete or movements overhead going in the anterior direction, then you should probably also load that area.
Yeah. And if someone else doesn't have, should I just
Yeah,
ask
I've
my
got a
last?
couple more questions to add, but you keep going.
I guess the other question was, I find like you said, where when you have that resistance sort of training and you're tailoring it and you're modifying it with the patients, and you find that okay, they're fine and they go off, and then they come back after some time. So do you tell them or give them the tools that they can do a maintenance program? Because I often tell those patients that yes, like you're feeling better, but as any athlete would do, then maybe at least follow some set of exercises as a maintenance program so that you don't get those, spikes in between.
Spikes or fluctuations or
Yeah.
Well, it is definitely something I recommend, and it's something that we know is useful to have these longer periods of exercise. We know it's difficult. It's difficult for people to maintain, especially if
I
the
know
symptoms
people to say how
have
long.
improved. It's really difficult to continue doing the exercises if the symptoms are better. What is very interesting also regarding the physiological adaptations we were talking about before, There is a knee study from May-To et al. Who looked at people without hyperlaxity or without generalized joint hypermobility, compared it to people with generalized joint hypermobility, but not fulfilling the criteria for what they define as a hypermobility syndrome. And then they had patients with benign hypermobility syndrome, and they all had knee pain. And what they found was that when they introduced strength training for the knee, all patients had the same rate of improvement in their strength.
Mm.
But the ones with benign joint hypermobility, they started at a lower point in strength. So it took them months to reach the same baseline level as the ones without generalized joint hypermobility.
Mm.
So I tend to say to my patients that you can get stronger with the same rate as anyone else, but you probably start at a lower level. That means you need to exercise for longer durations, and that is maybe something we could use to educate them about the reasons behind the need to do ongoing exercise.
Do you think that,
Right.
yeah, have any thoughts around why they start lower? Like why they start at a lower level? I guess these people are symptomatic, maybe. Is that, yeah, do you have any thoughts around that?
Well, they were all symptomatic in the knee, but they
Yeah.
somehow had different criteria. But one of the reasons is that we know from studies like examining tendon stiffness and
Mm-hmm.
also
Mm-hmm.
muscle stiffness.
Mm-hmm.
We know that the muscles and tendons are softer, and that could probably be a physiological reason why they can't produce the same force or
Yeah.
have the same
Yeah.
levels of strength. It's difficult to say. We know it's a very challenging issue with this
Mm.
population that they have weaker muscles and they fatigue earlier.
Yes.
Um, but the reasons are multifactorial, I would
Yes.
say.
And part of that, like you say, is probably the extensibility of that tendon. I guess the encouraging news is eventually they will get there. Hey, like eventually that tissue tension in the tendon will change and the muscle will eventually hypertrophy and yeah, that will change. It just is harder work, which is, from the it's always the maintenance though, isn't it? As we're speaking to, is harder
Yeah.
especially when they're pain free.
Yeah, and we should also recognize that doing progressive high-low strength training has so many other benefits.
Yeah.
So you don't necessarily need to have more strength to get the benefits. We can see that with our client case study, that after maybe just 4-5 weeks, they have the neuromuscular adaptations. They have learned to control movement,
Mm,
and that is sometimes sufficient to have less
mm,
pain and better
mm,
function. So it's a method, it's a strategy we can use to
mm,
introduce high load strength training, but it's not always only to achieve high load
mm.
or higher strength.
But it's also interesting to understand because obviously you are then with the strength training, you are changing the neuromuscular patterning. And I guess some of Pradnya's questions that we had discussed after the podcast were that often some of these patients present with the patterning, but patterning changes, patterning alterations. But you've sort of answered that earlier in terms of paying attention to the quality of the movement. It's not, you're not saying just lift something heavy and keep lifting. That's not your message, is it?
Not at all, no.
Yeah. So it's good to clarify that. I've got a couple more questions for you. One of them is around rate of force development and your thoughts on rate of force development in this population and maybe that comes on from tendon extensibility. Is that what and how clinicians can reliably measure that? Do you have any thoughts in that space?
Well, I mean, measuring rate of force development is the same. I mean, the approach of measuring it
Hmm.
will be the same in hypermobile populations. Uh, I would expect it to be lower. That is what we see in our studies, also in some unpublished data, that the rate of force development is lower, and it really makes sense because it takes, I mean, you need lots of stiffness and lots of explosive movement. And if you have these soft muscles, soft tendons, it's difficult to create that stiffness with high speed. So, and the way you can test it, I mean, you can do basic tests for rate of force development. It could be the ASH test using force blades, or different kinds of like the Cybux isokinetic device to measure that. We don't have much data showing anything about hypermobile individuals and their rate of force development. But I mean, in practice, it's good to focus on it, especially if you have to do with hypermobile athletes. It's good to consider that isometrics or only slow high load strength training is not going to prepare them for their sports. So I would definitely introduce high speed, explosive exercises, plyometrics for the upper limb and so on.
I've been having some conversations with Adele Fanning around the contact athlete and the hypermobile contact athlete. I think particularly post-surgical is the main population she works with. Have you got any tips around that? I guess so. Now we're thinking more that explosive high-end athlete who is also hypermobile. Any thoughts in that space? And now that we've dealt with their plyometrics and their speed,
Yeah, yeah.
any other
Well,
genes?
I've had recent experiences with posterior instability in football or soccer players, like European football players, and what is very useful, especially in dislocated like athletes with previous dislocations, is to work with loading and also rotational forces with high speed. So that could be, let's say you are doing a plank on a medicine ball, and then you have to go from in different rotation directions. So it could be from prone to the side plank position on this medicine ball.
Yes.
Could be working like backwards. If it's anti-instability, you could lie on the elbows on the
Yes.
medicine ball and then do some rotations up here.
Yes.
Could also be like tackling a medicine ball against the wall, where
Yes.
you have like different directions. And
Yeah.
what we found using EMG, electromyography analysis, we found that it really matters if you are in standing, if you are in the lying position, and it also matters if you have your arm in a normal neutral position or you're more adducted in the position. So everything matters, and it's so important that
What do
we
you mean matters?
use.
Explain matters. What is it?
So what I mean with matters is that you can't just do one exercise in one position. If
Yeah,
you're
okay.
working with athletes, you need to consider all the external impacts that
Yes.
will affect them, other like opponents,
Yes.
forces in all directions. If they fall down, which direction do they fall? How is their arm positioned, and so
Yes.
on. You need to consider that when you design your exercise. And when you look at the muscle activity around the shoulder joint, it matters for the muscle activity in which direction you do these exercises.
In that you
So
get
one
more in one direction than another. Is that?
Exactly,
Yeah,
exactly.
okay.
And you have different co-contraction depending on if you do
Okay.
something slowly or you do it with faster speeds.
Tell us about that. That sounds interesting.
Yeah, what it again, it's based on clinical experience. We have
Yes.
played with having some electrodes on the muscles and just
Yes.
looked at the activation pattern, and you
Yes.
can basically see that in some positions, depending on again what position your arm is in some
Yeah.
positions you have like higher peaks of muscle activation in some muscles, and in some position you have more co-contraction of all the muscles.
Okay.
And that is, I mean, it's difficult to explain because it depends on which position we're
Yes,
talking
yes,
about and which
yes. There's,
muscles we're talking about.
yes.
But just the idea of knowing that an exercise, one simple exercise, can be hundred of exercises if you think
Yes.
about muscle activation, if you think about different co-contraction patterns and so on.
Yeah. Yeah.
But it's something we need to research even
Further
more in
explore.
the future. Yeah.
Yeah, that's fantastic advice. I guess the final question, we've got one more minute left before my 30 minutes are up. My final question is around labral repairs then in this pathology, in the hypermobile patient, because we know then that Pradnya and I met with some people the other day now, posterior instability on a background of a anterior labral repair. Have you got any other, like aside from trying to then restore normal movement, normal passive range, do you have any other tips in that space?
I think it's extremely important to have strength in those positions where the posterior instability occurs.
Hmm.
So it's extremely important to address that instability or apprehension. If there is posterior
Hmm.
apprehension sign, it's extremely important to somehow build capacity in that region.
Mm.
And when you have some kind of an instability, you should also see if there is some kind of a limitation related to the translation of the humors.
Mm.
Especially after surgery, you could have maybe less anterior translation. It also depends on the surgical procedure. So
Mm.
if it is an anterior instability that is treated with Lattaché surgery, then you could have less anterior glide of the glenohumeral joint,
Mm.
and then you should try to address that.
Mm.
Um, so again, it really depends. I would say depends on
Mm.
the symptoms of the patient and what you find clinically
Yeah,
in the tests. Yeah.
yeah, right. Pradnya, did you have any closing questions? You?
No, I think you've answered more, and I think the more we've discussed, I think there are more questions which are popping up. So, what
I, I
isn't
must work
it?
on my answers then.
No, it's great.
That's fascinating. It's fascinating. Well,
But
thank you very much for your time, Ben, and we appreciate you
Thank you so
making
much for having
yourself
me.
available. It's been so wonderful to dig further into this. Like we say, the more we learn, the more curious we
have
are.
questions.
So thanks again for your time.
Such a pleasure talking to you. I hope to see you one day in New Zealand.
Yeah,
That would be
yeah, come
great.
out. We'd love that.
Thank you. Thank
Yeah,
you.
thank you.
Thanks for your
Thanks a
time.
lot.
That's
Take
really
care.
wonderful. Thank you. I really very much appreciate it. I know you have to run now and you have a busy day, but it's so nice and it's really great to
Thank you
understand
so much.
the detail of the work. So yeah, thank you so much.
Thank you. Hope it made sense. So,
Yeah, yeah, yeah. We've got lots to talk about now.
yeah. Take care.
See you later. Bye.
See
See
you.
you. Bye.
Bye.
Thanks for joining us. Cheers.
Cheers.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well. Take care.